Bismillah Rahman Rahim. Assalamu alaikum and good morning. I am Dr. Faisal Ikram, working as consultant gastroenterologist in the Department of Gastroenterology at Sedu Group of Teaching Hospitals, Swat. I welcome you all to the session number 6 of the 41st annual PSG Conference happening here in Peshawar. Like the previous session, this session will be having talks related to advanced and interventional GI endoscopy. Before going to the start the session, I would like to invite the chairs for this session on the stage. So the chairs for this session are Professor Dr. Anwar Ahmed Khan, Professor Dr. Jafri, Faisal Jafri, Professor Dr. Kashif Malik, Dr. Muslim Atiq, Dr. Habib Jadoon, Dr. Mazbin Badsha, and Dr. Junaid Salim. Please welcome them on stage. Okay, so now we are moving to towards our lectures. The first lecture will be delivered by Professor Dr. Saad Khalid Niaz, who is consultant international gastroenterologist at the Sindh Institute of Advanced Endoscopy and Gastroenterology. His topic will be difficult CVD stone management. Please welcome sir on stage for his talk.
Bismillahirrahmanirrahim. First of all, I'd like to congratulate Professor Ghias and the whole team for doing this journal launch, which has been pending for, I don't know, more than a decade, or maybe even longer. A great job. So we're just going to discuss how do we manage difficult CBD stones. What is a difficult CBD stone? This is our unit. What is a difficult CBD stone? I think there are some features here which we'll share, but I think one of the important factor is one's experience. It obviously what may be a difficult stone for me may be a very easy stone for Waqar and Riyas with their experience. So it's not because the stone is difficult, it's because I need to learn more and get more experience, understand more techniques. ESGE says any stone that's more than 1.5. ASGE says more than 1. I think less than 1.5 centimeter stone, unless it's a special shape, I am not sure is really a difficult stone in this day and age. If there are more than one stones, they think both societies feel that it's difficult. Depending on the position, if the stone is impacted, doesn't allow anything to go through, duct size is small, agreed. Barrel shape, eccentric shape, I guess very similar. But what is important is if you have a stone that is square or rectangular shape, even if it's small, sometimes it can be difficult. Consistency, according to ASG, hard consistency is more difficult. Again, as I said, it depends on the size and shape. A hard stone can be easily pulled out. Bile duct anatomy is obviously very important. And previous failed attempt. Again, this depends on who the person is who's doing this new attempt. How experienced is he and what modalities is available to you. If you're going to embark on actually removing large or difficult stones, then you need to make sure that you have everything that you need to deal with it, including experience. So access can be difficult. Configuration and location. We have just mentioned, and these are just some pictures that you can see. We saw a nice case presented by Dr. Nadeem Tehami of Mirici syndrome. And I think a lot of patients that are referred to me by less experienced endoscopists, ERCPs, quite often they're actually trying to remove Mirici's stone through the CBD, and that's not going to happen. So the stone is stuck in the middle of the CBD and it's not moving. The duct below is not dilated. Think Mirici's. If the duct, as we mentioned already, large stones and shape we've already discussed, and you can see the samples there. So that's an example of an impacted stone. If your experience is very easy, if you want to do fistulotomy, this is a very simple case to do fistulotomy or needle knife. Then you see two stones here which are large, and the duct is not very dilated. If the patient already has a stent, remember the duct is not going to be very dilated, so keep that in mind. Here you have a duct which is dilated as well as multiple large stones. And again, difficult stone, but stuck here. It would concern me because unless I see the dye going from this side, I would be very suspicious of this being a Mirices. So if you try and take this stone out and it's not actually in the CBD, you will just be, I think the best thing is just to put a stent and come out unless you have other modalities. And you can see another large stone. So multiple examples here. Just to tell you, cholangiography for stone detection, just basic. Most of you who are doing ERCPs, this is, so slow injection, full versus half strength. We use half strength. It's better for stones. Take early films, or if you're doing fluoroscopy, obviously just keep an eye on it. Fill distally first if obstructed, and then obviously you move your catheter up and then inject. I personally go up first. If I can take my cannula up, I inject from up down. That way I ensure my stones will not go up into the intrahepatic system. And it's always important to turn your scope if you can't see, because quite often this particular area is blocked. And if there's a small stone, you can easily miss it. So it's important to jiggle your and move your scope. And we've already discussed about Mirices. Balloon extraction, the do's and don'ts. You all, those who are using balloon, you actually take the balloon up, inflate, and you have balloons that come in graduation, so they're 8.5 to go up to 15, and some balloons go up to 18 and 20. Depending on the size of the bile duct, if your bile duct is 20 and you're trying to pull a balloon that is 8.5 or 11.5, likelihood is it's going to come alongside. Go fill the balloon, inflate the balloon, pull the balloon down. The important thing is when you actually removing the stent. In the workshop we had very good examples. In fact, we had two difficult stones, and both of them required sphincteroplasty. Just can play this. So this is a patient post sphincterotomy with stone, and you advance the balloon and you can see the stone come out. The problem in Pakistan is balloons are expensive, and if you're not careful, you're going to, especially if you've crushed a stone, and that goes more for pancreatic duct, the balloon's going to burst. That's 35,000 rupees gone. And so you need to be careful. We don't try and pull large stones with balloons, because doing a sphincteroplasty following balloon extraction is easier than trying to bring out a large stone without. As I mentioned in the workshop, now our practice is that we would, with the balloon, we would go in, after sphincterotomy, inflate the balloon to max and pull it out distal to the stone first. That helps me to know my sphincterotomy is adequate size, and also, any fibers that are there which sometimes can make it difficult for the stone to come out are help that way as well. Balloon doesn't get stuck versus basket. It's simple, but one has to remember you need to be careful. If you're doing practice and you're going to be charging your patients, you need to be careful about these things. Okay, so what do we do with basket? Don't push stone into the intrahepatic duct, whether it's with the balloon or with the basket, sometimes can be difficult. Open basket alongside the stone, right? Get the stone within the basket wires, pull back. Now the important thing is, do not If you have multiple stones, go for the distal stone. If you get the proximal stone and try and pull it out, and the distal stone is bigger, you have a major issue. The basket should not be closed. That stops or reduces the chances of impaction. And I don't close the basket completely ever, except for when we are doing lithotripsy. I do not recommend using standard baskets anymore. I think trapezoid basket is my go-to whenever we want to use the stone, whenever we want to use the basket, because if you get stuck, you can crush it. Oh, sorry. So, basket, it doesn't break. With small stones, it's not a problem. The only thing is you should know how to actually get out if you're stuck or your stone is within the basket. How do you take it out? And you jiggle the basket, take the basket to the proximal, and usually the stone will stay back. The basket will go into the intrahepatic system, and you jiggle and come out. Is we use it a lot in bigger stones because that's cheaper than using spyglass. And in most cases, lithotripsy basket like trapezoid is pretty effective. And whenever we remove the stones, whether we have used basket or balloon, an occlusion cholangiogram at the end is a must. Coming to EHL and spyglass, about 80% of patients that are referred with large stones to us for spyglass are actually removed without spyglass, either with better sphincterotomy, more adequate balloon, or use a basket. We don't charge our patients for spyglass, but somebody pays. Nothing in this world is free. Someone is paying. And so we are very careful, and I think that's important. So here's an example of the spy scope going. I don't use the guide wire to insert the spy scope. Most of the time, I want the spy scope to go in when I've done a sphincteroplasty. In most cases, we try and get in anyway because we try first everything else before you use the spyglass. So you can see the stone is there, the stone's been crushed, and then you remove the stone with the basket. So there's a international consensus on balloon sphincteroplasty. This is going back to 2016. I think in the last maybe 9 years, the usage has has become much more common. It's important. There is a debate. We'll discuss that in a minute. What is endoscopic papillary large balloon dilatation? Anything more than 12 mm. I very rarely use 12 mm, to be honest. 13.5 would be the lowest, and then going up to 15 most of the time. You really don't need 18 or 20. It's only when you can see the stone coming out and it's stuck and you feel there's just that little resistance, I think it's worth doing 18. Otherwise, it's much better if you have other alternatives, safer alternatives, to use them. It's important how much do you dilate also depends on the size of the duct. So obviously we assume that all the, remember the caveat here is if you've got a stent, you can't rely on ductal size. But the duct is an expansile tube. So when you stretch it, and what you can do is, if you're not sure, you can actually use a stone extraction balloon, inflate it, and you'll know whether the balloon is actually nicely stretching the duct or not, and then you can actually stretch that much if you want to. Technique is, I think it's we've already shown in the workshop, and you put the CRE balloon, whichever company you use, insert it over the wire, and most of the balloon should be inside. The balloon has the tendency to either go up or come down. It's important if you see stones impacted at the lower end not to inflate unless you move the stones up. So you keep doing this under fluoroscopy. And it's important to have a decent cholangiogram there. Let's just see if we can show quick sphincterotomy. And this is something that we may differ on. I personally believe that whenever you're doing a sphincteroplasty, you should do an adequate sphincterotomy with an intent to remove the stone. And if you can't remove the stone, you shift and do a balloon sphincteroplasty. There's more space. Sphincterotomy, you need to be careful because you don't want, if the stone's small, there's no point going all the way. But if the stone is big, then you need to make a decent sphincterotomy. And once you've done that, you insert the balloon, inflate it. You can actually visualize the duct through the balloon. Sometimes you can also see the stone actually. Once you've done that, you feel like going in with your scope into the duct. Don't try doing that with the side view. But you can use your small scopes, pediatric scopes. And once you've done that, you can remove very large stones. So what about stone clearance? I think overall success is very good with this. The two issues about side effects, complications, the fear that it causes more perforation is actually not been substantiated. As far as bleeding is concerned, since we've been doing it, I've only seen one major case of bleeding, and that patient also was on dialysis and had CRF. And I think those are the patients one has to be very careful. But otherwise, I have seen trivial bleeding, but they stopped. I discussed this at the workshop that I, as a practice, now insert the balloon, inflate it, do the sphincteroplasty, and I will not remove the balloon. I keep my balloon in, and if there is no bleeding, fantastic, come out. If there is bleeding, you wait. If there is a little bit more bleeding, then you just re-inflate the balloon. You don't have to go all the way to 15, if you've done 15, even 13.5, and just leave it there for 3 to 5 minutes and come out, and most of the time you achieve hemostasis, and you don't worry afterwards. So I think balloon is very safe. So what options do we have? If you have a difficult CBD stone, you straight away go for a decent, if the patient has been referred from another center and the sphincterotomy is not adequate, we can extend sphincterotomy. We used to worry about bleeding. I think that is based on very old studies. I haven't seen significant bleeding in extending sphincterotomy that is inadequate. If the sphincterotomy is inadequate, extend it. Look at the size of the stone. Look at the shape of the stone. Look at your and what accessories you have. Best thing here is if you don't have everything and you think the stone is difficult, put a stent and come out, and send the patient to somewhere else where at least you will not be accused of causing a complication. The last thing you want to do is try and take a stone out, use a basket, or use some device which you are not familiar with, or you're stuck with. So if your basket is stuck, there are a couple of options. You can dilate, do a sphincteroplasty, and remove the basket that way. There are emergency lithotripser, or where you can actually cut the wire and actually crush the basket wires so that the basket comes out. Now all those things should be there. If you're going to use these things, you need to have the backup in case you get stuck. If sphincterotomy doesn't work, you go to sphincteroplasty. Usually average sphincteroplasty for a stone which would be 1.5 or considered difficult would be 15 mm. After sphincteroplasty, the patient, if the stone doesn't come out, you can use basket if you use, but use a basket that has ability to crush. The standard basket for large stones must not be used, in my opinion. And if that doesn't work, you can put a spyglass. Mirici syndrome, in our unit, honestly, I don't remember last when we have sent a patient to surgery. In the last 2 years, we have the exact data, and we have done over 4,500 ERCPs. And on those 4,500 ERCPs, we've not had a single patient who had to go to surgery for large stroke. Thank you very much. I can just take one. No, I don't have that slide. I just wanted to tell you that we do courses, ERCP hands-on courses. Dr. Vakar just mentioned that. Those courses, we only have 5 candidates selected. We have faculty from Pakistan, UK, and US. And that would be advertised through our website, and we'll try and get PSG to actually also share that. And we're also doing Train the Trainers course. We did one last year for ERCP. We've done a few for colon. So I think those who are doing and want to train, that's a very good course, and we all learn a lot. Thank you very much.
Thank you, sir, for discussing the management of difficult CVD stones in detail. Now we are moving to our second talk, and it will be presented by Professor Ghayasun Nabi Tayyib. Actually, he'll be delivering 2 talks back to back, one with the topic of recent practices and future trends in the third space endoscopy in Pakistan, and the second one will be with the management of achalasia. Please, sir, come on the stage.
Thank you very much, Dr. Kamran, Dr. Shehriman, for inviting me here on this 41st Congress of Pakistan Society of Gastroenterology. It has been a great pleasure, great hospitality so far, and great organization all the way. So, third space endoscopy, I know, are you going to start from there or from here? Right. So the topic given to me is third space endoscopy, recent practices and future trends in Pakistan. Now, I'm sure I don't have any disclosure. This is the second talk that I'm going to talk about. It's a philosophical talk, more on the costs, benefits, and risks in low-income country. I think the topic given is more to do with is there any actual utility of third space endoscopy or not? Now, yesterday we were listening to our Japanese colleague. And he was talking about EST. Now, unless we have this third space endoscopy poem, these are all overlapping things. Nobody can do EST unless a person is good with the dissection, and that's exactly what we do. And the starting point of EST is again maybe poem, because that's the easiest kind of EST. I don't have any disclosure pertaining to these slides. Now, what exactly constitutes third space endoscopy? There are lots of young people sitting in the hall. First space is obviously the kind of endoscopy that we do within the lumen. Second space is the kind of surgery which is done by the surgeons. So in between the two, between the luminal layer and between the visceral side, outside the lumen, this is called third space, meaning by the submucosa and the muscular layer. This is called the third space. And third space means that per oral endoscopic myectomy, may it be in the esophagus, may it be in the stomach, may it be in the rectum, may it be anywhere else in the GI tract. So that's what we call third space. And the prototype is achalasia cardia. And what are the different treatment options? First space treatment in the achalasia treatment is botulinum toxin that we have always been doing, or maybe the balloon dilatation. So balloon dilatation and botulinum toxin, these are the two first space treatment used in the achalasia cardia. Second space treatment, obviously, laparoscopic Hell's myectomy, and third space treatment prototype is per oral isophageal myectomy, and that's the commonest one. So, in summary, if you look at this slide, these are the different options that we use in the therapeutic option in the achalasia cardia, pneumatic balloon dilatation, Botox injection, laparoscopic Hell's myectomy, and poem. So the third space, the new frontiers of surgery, nasal orifice of transluminal endoscopic surgery, that was a term used by Kalu many years ago when I was also under training, and ever since that time the evolution has taken place. with the first publication in 2008 by Ortega and followed by Inva, the first live demonstration back in 2009, the POEM procedure has taken as virtually replaced eclasia cardia management, pneumatic balloon dilatation, and left myectomy all over the world. Currently, more than 1 lakh procedures of third space myectomy has been done all over the world. So the technology has been involved in it. Multi-role therapeutic endoscopes have been introduced for this, and this is an ever-expanding, minimally invasive armament procedure going to so many other places. So if you look at this video, you'll see how easy and how comfortable is it to do ecclesia cardia management. In the interest of time, I'm going to push it through. First of all, injection, making a bleb submucosally. Once the bleb has been made, then cutting the mucosa in order to get into the submucosal space. And how do we do it? We create a submucosal space, enough space to push the endoscope down into the space between the mucosa on one side and the muscle on the other side. And once we in that space, then we start dissecting the submucosa by injecting the saline. That's a diphenol saline, and we continue dissecting all the way down to the EG junction. And once we are down at the EG junction, we have identified that we are in the stomach. Then we start cutting proximally, and we do the myectomy. So these are the different steps that we do. And the defect that we have created, that defect is closed. This is the myectomy that we do, and the defect that we have made, we close it with the help of clips. And how many clips? 3 or 4 clips, not many. So all in all, what are the things that we are using? Not a lot. I've already said that we are using, number 1, injector needle. Number 2, we are using an endoscopic dissection knife. Number 3, we are using clips. So these are basically 3 kind of disposable that we're using. And the extension of POEM, now we're doing gastropexy in the people who are suffering from gastroparesis. Yesterday, Professor Javed Farooqi was talking about functional dyspepsia. The worst form of functional dyspepsia is idiopathic gastroparesis. May it be a diabetic person, may it be an idiopathic gastroparesis otherwise. When the medicines fail, obviously the endoscopic therapy comes. And endoscopic gastropexy has again revolutionized the treatment of functional dyspepsia. Hirschsprung disease. Not many centers are doing the dissection on the rectal side. Why? Because the rectum is quite ballooned up. And when we introduce the air, it balloons up further. So technically it's challenging, but theoretically, yes, it is possible to cut the muscle instead of going through a major surgery in a young child as young as 3 to 4 years, doing it endoscopically in a minimally invasive fashion, doing the surgery in the morning, sending the person home by evening time. What else do the parents need? And similarly, in an elderly person at the age of 75 or 80 with a Zenker's diverticulum, if we are able to do it minimally invasive fashion, we are doing it in the morning and sending the person home by the evening. What else the family of an elderly gentleman suffering from significant dysphagia, not able to eat, coughing all the time, that person needs? And the things are going even further. That is submucosal tumors, the stir. And even going beyond that, cutting the muscle and going towards the lumen, the people have started to remove the tumor. So personally, I have not done the stir yet. Personally, I have not gone beyond the muscle. We have done up till now E point, we have done G point, we have done Z point, we have done D point. So these are the different procedures that we have done up till now. So first case done, I've already said, by Ortega, and then displayed live by Inva. Ever since that time, there's been a huge success. Now, is POEM effective? That's the first thing. Whenever a new procedure comes, we always say, is it effective? Is it going to help the patient? The answer is yes. The number of studies which have been published up till now, you can say the technical success is above 90%. So a procedure which is successful in more than 90% of cases, that means that this is going to stay with us for the coming days. Now, is it safer and more effective than pneumatic dilatation? We all know We have been doing pneumatic dilatation ever since we have started our journey in gastroenterology. Pneumatic dilatation is no doubt effective. It is easy to do, but how effective is that? In the best of the hands, it is not more effective than 54-55% of the cases. This is the meta-analysis which has been done on this subject. How many people develop complications? Roughly 5% of the people develop complications, and these complications are major. Once these complications develop with pneumatic dilatation, nothing short of surgery works. So on this side, in the E-poem, we don't have any significant complications, except for transient complication, maybe chest pain, maybe mild degree of fever, or down the road, people say 15% of people develop reflux disease, but in our patients, it is less than 5%. So we can say that it is definitely more effective than pneumatic dilatation with lesser complications. Now, talking about the gold standard, for every new procedure, we always have a gold standard, and the gold standard is laparoscopic Hall's myectomy. And as compared to laparoscopic Hall's myectomy, we have lesser complications in E-poem. We can cut the muscle for longer length. So all those cases, especially type 2 achalasia and type 3 achalasia, we can have a longer length of muscle cutting, and the technical success and the clinical success rate gets improved. Since the patient doesn't have to stay for long, and patient doesn't develop all kind of complications that comes with laparoscopic Hall's myectomy, so it becomes definitely cost effective. And in type 3 achalasia, definitely it is better. So what are new frontiers? Can we do E-poem in all those cases which have been exposed to the previous treatments? The people who have had Botox previously, yes, we can do it in those cases as well. People who have been subjected to pneumatic dilatation, can we do it? Yes, in those cases as well, we can do it safely. People have gone laparoscopic Hall's myectomy, can we do that? Yes. And the people who have undergone POEM previously and they have failed to respond at a different direction, a different angle, we can redo the POEM in those cases as well with an equally good success. In exclusive circumference, can we do it in younger population? People as young as 3 to 5 years? Yes. The youngest that I've done is 5 years. But the youngest in the world that has been done is 3 years. In people who have got advanced degree of disease, where we straight away say, look, this is not going to, no treatment is going to help, go for esophagectomy because there's a high risk of cancer. But over the years, there have been a number of reports that even with these advanced, grossly dilated esophagus, which we call megaesophagus with stigmatization, once we do the muscle cutting, over the years, the lumen gets straightened and the people improve in those cases as well. Can we do it people who are suffering from cirrhosis with significant basis? Yes, people have done it with good results. All the personally have not done it in a cirrhotic patient, but yes, it can be done. Can it be done in pregnancy safely? Yes, it can be done in pregnancy as well. So just to summarize the efficacy POEM, in type 1, type 2 achalasia and people who got EGO obstruction, it can be done safely. Pneumatic dilatation, previously done, yes. It is better than pneumatic dilatation. It is equally effective than laparoscopic Hall's myectomy, but with the advantage that we can do it more safely. People can be sent home. In jackhammer esophagus, in people who got diffuse esophageal spasm, it works very well. POEM is definitely preferred in these cases, and people who got comorbidities, it is effective. Now, E-POEM, is it difficult to learn? Is it difficult? Can you develop a setup in your own center? The answer is yes. We developed it. Dr. Sadhya has developed the setting, and similarly, the people who have been working with me, they learned this procedure, and in Lahore, there are at least 5 centers who are doing E-POEM at the moment. In Karachi, Dr. Sadhya is doing the POEM. So if these 2 centers can do in Lahore and Karachi, why can't you develop in other places as well? The answer is yes. It is a learnable, teachable procedure. And let me tell you, in the gastroenterology, the most difficult procedure, even at this stage, that I foresee or that I understand is I'm still the one procedure that I think that I'm afraid of is ERCP. And as compared to ERCP, this procedure is much more safer and much easier to learn. What are the complications? Mucosal injury. In case mucosal injury takes place, what's the solution? Just a clip. In case there's a delayed mucosal closure failure, which occurs in less than 1% of the cases, the answer is again mucosal clip or maybe suturing device. Delayed bleeding, yes, it does occur. Hemostatic devices are quite effective. Hydrothorax occurs rarely. It has been reported in the literature. Luckily, in our cases, all the cases that we have done, it has not been a problem. Pneumothorax occurs transiently, normal thing. Pneumomediastinum, pneumoperitoneum, and subcutaneous emphysema are part of the procedure. So we don't take them as complication, although in literature, they've been taken as complication. The concerning issue, learning curve, roughly about 25 cases for the person who has not done many cases. Availability of resources in low-income countries, I'm going to come down to that shortly. And GERD, 15% is reported in the international literature. In our cases, in our series, it's less than 5%. So, problem is there once you cut the muscle. Otherwise, in the population, we have a GERD incidence of roughly about 10 to 12%. So, if in postpoint cases, we find that in about 5% of cases, the people have dependency on omeprazole or PPI, will not take it as out of the box. So GERD can be maybe a part of the procedure, maybe as a part of the spectrum of the disease which occurs in the family. So in summary, POEM algorithm, category type 1, standard myotony type 2, achalasia type 2, maybe extended myotony in type 3, even more extended myotony. At times we cut it as long as 18 to 20 centimeters as well. In diffuse facial spasm, jackhammer figures, we do the LES preserving myotony. So what are the instruments required? This is the list of instruments which are required in doing the third space endoscopy. And these are not very complicated instruments. These are simple, straightforward instruments. I understand that there are lots of companies who are marketing it. And then there's been an attempt in the country as well to make these instruments. Maybe right now they're expensive, but down the road, once these procedures become are being done by more number of people, the availability of these machines, availability of these accessories is going to get more, and you'll be able to get them cheaper. So what is the diagnostic workup required for POEM before doing the procedure? An upper GI endoscopy to see and to confirm the diagnosis and to confirm that there's no stasis of the foot, there's no candidiasis. If the candidiasis is there, one is to give treatment for 15 days. Time barium isophogram, just to be sure that we are dealing with achalasia, and that has to be supplemented by high-resolution impedance manometry. Endoflip is a research tool. We don't do it, we don't have it, but the centers who are using endoflip, they think that it helps in improving the outcomes of the thing. What do we get in the esophagus in the endoscopy? Usually the stasis of foot. This is the typical picture of endoscopy in a patient suffering from achalasia cardia. And in time barium, we expect that 50% of the column should stay there in a 1 minute film. So this is the picture of high-resolution impedance manometry. All those who have appeared in the FCBS part 2, most of the time they get this film. If there's increase in pressure in the lowest renal sphincter, straight away we say that this is achalasia cardia. But the important information that we want to get on the basis of high-resolution impedance manometry is the typing. Are we dealing with type 1? Are we dealing with type 2? Or are we dealing with type 3? So as a technical information, as a technical person, I want to have the information. If it's type 3, it's going to be extended myotony. If it's type 2, the myotony has to be longer than that we do in the type 1. So are the patients able to go home? Usually we send them home by the next morning, but they can be sent home on the same evening as well if the procedure has been done in the morning. Can the people take the diet right away? The normal diet, khaba shaba, जिस तरह खाना हमने कल शाम को खाया, The answer is no. They have to be taken slow and steady to the final diet. For the first couple of days, just the liquids. For the next 3-4 days, a little something more like soft diet. For the next 4 or 5 days, semi-solid diet, and after 14 days, we ask the person to take the normal diet. How many cases have we done up till now? LGH Doctors Bahria, Gulab Devi Hospital, we've done about 425 cases. 315 were naive, 110 patients were treatment exposed. Out of them, 80 had the pneumatic dilatation. Mean age was 55 years. Technical success was 100%, with clinical success was 96%. We did the repoem in 10 patients as well, and surgical laparoscopic hydromyopathy were 20 patients. So complication: one, misperforation, repaired endoscopically, GERD, heartburn in 35 patients. It's not a lot, and average hospital stay was 24 hours. Now, switching to GPOM, we have done more than now 20 cases. Treatment for gastroparesis, particularly people who are suffering from uncontrolled diabetes, who are losing weight, who are throwing up continuously, not responding to the available armamentarium discussed by Dr. Javed Faruqi as in yesterday's publication. There's enough data in the literature which makes us understand, which makes us believe that GPOM works and GPOM is effective. If you look at this this video, you can see that we make a vertical incision or we make horizontal incision. Rest of the steps are exactly the same as in the EPOM. We make a dissection, we go all the way to the pyloric muscle and then cut it back, and the whole thing gets stretched up again with the help of either suture device or with the help of clips. So the cutting is a little deeper. Generally in GPOM, unlike EPOM where we try to cut just the circular muscle, in GPOM we try to cut full thickness muscles, and that's the difference between GPOM and EPOM. Otherwise, the rest of the things are the same. And by the end of the GPOM, we expect the person to have this kind of pyloric opening and not the typical rounded opening. ZPOM, this is the case that we did recently, a deep diverticulum, roughly about 4 centimeter, as evident on this spherogram. And we cut this muscle, but the target is this muscle. And if you look at this video, this is a small video. Sorry. Starting with the spherogram and then CT scan. Am I given 30 minutes or 20 minutes? So my technique is a little different from what the people practice elsewhere. I make a bleb, I dissect the two sides of the muscle, expose the muscle properly, and then with the help of a scissor, I cut the muscle all the way to the bottom. And then once I've cut the muscle, I stretch the defect with the help of 2 clips, and that's usually good enough. Generally, there are a good number of vessels, and they can be coagulated with the help of coag Rasper, which are pretty effective. This is a scissor device with the help of which we cut the muscle. And towards the end, just these 2 clips, which are good enough to close the defect. Similarly, we can do DPOM, and at the same time, we can do PREM in the cases who are suffering from Hirschsprung disease. Subepithelial tumor resection, they can be done in the exactly same fashion, exactly same technique. Personally, I have not done any, but people in the neighboring country, India, they're doing it in routine, and they're in the other parts of the world, again, they're being done in routine. Next part of my talk is more on the philosophical side, cost, benefits, and risks in the low-income countries like us. I don't have any financial disclosure to these part of the slide, but definitely since I've started third space endoscopy, and I'm proposing third space endoscopy to all the people in the hall and to the country, so definitely you'll find some kind of cognitive conflict. So intellectual conflict is there, but I shall try my level best to stay neutral in this. So, over the years, we have seen, I'm one of the few people sitting in the hall, just like Saad Niaz, just like a few other people, who have seen the transition from fiber optic endoscope to the video endoscope, from high definition endoscope to the latest one, which got all kind of fancy fine imaging, and then from the office endoscopy to the mini OR type of endoscopy, and now artificial intelligence. Dr. Aslan Karu is going to talk in shortly. So all these things, this transition that we have seen. So developments in endoscopy. Can we stop the developments in third space endoscopy as well? No. In achalasia, historically we have transitioned from fishbone bougie to the most modern gadgets, to the plastic bougies, to the balloons, and from saline to botulinum toxin. And similarly, now the third space endoscopy is there. Can we stop the innovation? Uh, the answer is clearly no. The innovation has to stay with us. Poem started in 2008. Now it has taken the word all together, and nobody's doing, rather, very few cases are going for the laparoscopic Harris myectomy, and not many centers are continuing with the pneumatic dilatation, although in Pakistan still many centers are doing pneumatic dilatation. But to be honest, in rest of the world, the pneumatic dilatation cases are going down and down. It's effective. You have already seen this slide. Comparison with pneumatic dilatation, it is more effective. Comparison with the laparoscopic Harris myectomy, you've already seen this slide. It's more effective. Have we not transitioned from open to lab-assisted cholecystectomy? Those of the people who think that cost, benefits, and risks, is it not applicable in the cholecystectomy side as well? Are the people not already onto the laparoscopic cholecystectomy, and those centers who have the facility of robotic surgery, they are switched to robotic assisted cholecystectomy? The answer is yes. So the cost, yes, it is definitely more expensive as compared to the pneumatic dilatation. But remember, in pneumatic dilatation, we are using 3 balloons, 3 centimeter, 3.5 centimeter, 4 centimeter for the best efficacy. And each balloon costs 1,20,000. So if you're using disposable balloon, that means that in a single patient, the cost of the disposable is minimum roughly around 4,20,000. And similar is the cost of disposable in the third space endoscopy. So costs are definitely an important thing. But other thing like CO2 insufflation, once you have gone to this CO2 insufflation, I've gone to the CO2 insufflation in almost all the cases. Monitoring, you need monitoring in the in patients who have to undergo POEM, but then that monitoring can be used in the other cases as well. Threshold for EST knives has gone down in my personal practice. I've started to use them more liberally, more frequently for superficial submucosal lesions. If I have a hole, previously I used to send them to surgeon. Now what do I do? I simply pick up the clip and I close the hole. Then there are suturing devices as well. So as we learn to use new tools, we find the new applications as well. So when we talk of the cost in a particular procedure and start comparing it with X procedure, that doesn't mean that these costs are not going to help us in managing our patients better and in other sphere of the cases as well. So more the number, better shall be the availability of consumer. There can be better availability of the locally made instruments. What are we comparing? Third space endoscopy with pneumatic balloon dilatation or laparoscopic Harris myectomy or botulinum injection? Obviously, the third space endoscopy is going to stay and shall have more applications and is probably more beneficial for the patient. I've already said that's a teachable and learnable procedure. Learning curve is about 25 cases for the people who are at the intermediate level, but those who are senior endoscopists who have got well-developed skills, maybe 8 to 10 cases under supervision, they are good enough. What are the risks? I've already said training costs. Definitely training costs are high. And then learning curves. Few people are quick learners, other people are slow learners. But average learning curve, I've already said. Can we stop the innovation? I've already said the answer is no. Third space endoscopy, the spectrum has opened up hugely, enormously. In the coming years, maybe Norse, we start doing it in routine. We start taking out the gallbladder, all this stuff through the stomach hole instead of going through the interior abdominal wall. So I thank you for your patient listening.
Thank you, sir, for your detailed presentations on both the topics. Our next presenter is Dr. Shahzad Riaz, who is consultant and interventional gastroenterologist at Shifa International Hospital, Islamabad. He will be talking about acute pancreatitis, recent trends in the fluid management. Please, sir, come on the stage.
Bismillahirrahmanirrahim. So my topic is actually a bit boring and has been discussed a few times, but it is important, especially for the junior. So I'll quickly try to highlight the important points. I know a lot of our senior consultants have got an interest in painting. So I know Dr. Saad has got a particular interest. So can you identify this painting or the painter? Anybody? So this painting is from Rembrandt, okay, and he's actually depicting a theater. He painted a professor of surgery at the time, and his name was Nicholas Tulp, and he basically described the complications related to pancreatitis in one of his memoirs. So that's where it all started from. Another painting, I'll make the question a bit more easier, especially for the juniors in the back. Can anybody guess what this painting is about? What is the painter trying to depict? Anybody? Pakistan ke halat mat keh dena. Which will be more meaningful. But actually, it's a boat or a ship stuck in a storm. And the story goes that the painter, Turner, basically was so much interested in capturing the essence of a storm that he tied himself to the mast of a ship so that he can actually feel how a storm is before he painted this painting. And if you can use your imagination, the pancreas is quite similar to this boat, which is stuck in a cytokine storm. So it has fuzzy margins, it has no clue what's happening, and it is in trouble. And as the old sailors said, when a boat is stuck in a storm, the idea is not to reach your destination, it's to ride the storm. So yesterday when I was coming, there was again a hailstorm, and I was going to the dinner party. And as soon as the hailstorm started, my attention was not that I need to reach my destination. I wanted to just ride this hail. So, and just a point for the people in Peshawar, they were quite hospitable. So our car was actually pointed by some people to this, just like Dera Sa Bana Hua Tha. It was their private home. They opened their gates and they had, a large garage for 20 cars, and they allowed everybody, so they didn't care who you are, there's 20 people, of the car. So that was very hospitable. I don't think that will happen in Islamabad, I've never experienced that there. So bravo to people from Peshawar. So a few fun facts about the storm. So we knew from quite early on that if the storm is to be stopped, you have to intervene either prophylactically or, quite soon after the storm starts. So we were having this discussion in our endoscopy session whether the suppository, for pancreatic prophylaxis should be given before or after. And the overwhelming majority said that you should be giving before, because the idea is that the medicine should be there when this trigger starts. We know that there are several triggers for acute pancreatitis, but we still don't know that why do not all of these patients develop pancreatitis, and even if they do develop it, why do some of them develop interstitial and others develop necrotizing pancreatitis? We do, however, know that up to 25% of the patients develop the severe form. And although the treatment has changed, and we know we are better, at managing this condition, but the severe cases still continue to have a very high mortality, and therefore it is important if somehow we can predict the severity of the disease. There have been various ways, and a simple way is the Atlanta criteria, in which you can divide the pancreatitis into mild, moderate, and severe, depending on the persistence of organ failure. And then there are these much more complex scoring systems, and out of these, I tend to sort of prefer the BICEP score, which is relatively easier to calculate. You just need the blood urea nitrogen, the patient's impaired mental status, presence or absence of systemic inflammatory response, which is based on the temperature, heart rate, respiratory rate, and white cell count. If you know the patient's age and the presence of pleural effusion, you can then guess whether the patient has a relatively higher mortality or a lower mortality. So it's an excellent score to use. The ECG also suggests various ways in which we can triage these patients. So based on their characteristics, if the patient has got a high age, more than 55, if the patient is obese, has got altered mental status or comorbidities, then they are at a higher risk of developing a severe course. Similarly, with laboratory findings, if the blood urea nitrogen is high, if there is a higher hematocrit or the elevated creatinine, then that suggests basically indirectly hyperperfusion of the pancreas, and these patients will then end up with a severe course. And third space fluids, if they are having pleural effusions or extra pancreatic collections, again, these particular patients have a severe course. More recently, just last year, the ACG has updated its guidelines, and Dr. Mustafa Raihi did summarize them. So I'll just quickly go through a few points. So with regards to diagnosis, CT scan is not important, unless you are suspecting some sort of complications when the patients come in. Initial assessment has moved away from only looking at their clinical parameters. You are more now also looking at the laboratory parameters, including the blood urea nitrogen and the hematocrit, to exclude hyperperfusion of the pancreas. Fluid management, we'll be discussing this a bit more in detail, but essentially we're moving away from from aggressive fluid hydration and going towards moderately aggressive hydration with appropriate monitoring. Antibiotics are not advisable unless there is a clear evidence that the patient has got infected necrosis. The patient should be started with nutrition early on rather than keeping them nil by mouth. ERCP should be offered only if there is evidence of cholangitis. Otherwise, you should withhold the ERCP. Surgery can be offered early on in mild to moderate cases, for cholecystectomies. However, if you want to intervene for necrosis, then ideally, if it's better if you can wait for 4 weeks so that there's good walling off. So moving on towards the topic about the initial management, which is fluids, nutrition, antibiotics, and pain relief. So these are the four giants of the management of acute pancreatitis, and I'll be only concentrating on the fluid side of things. So if you look at the pathophysiology of acute pancreatitis, in simple terms, there's inflammation of the pancreas that leads to leakage of fluid through the capillaries, that then leads to hyperperfusion and necrosis of the pancreatic tissue. And we have known that, in the first 24, 48 hours, hydration is the only effective treatment in the management of acute pancreatitis. But despite various studies, we are still not entirely clear about the amount of fluid, which type of fluid we should give, and how frequently and how should we actually monitor these patients. So I'll be discussing each one of these separately. So the amount of fluid has been at the center of the management. And early on in the 1970s, it was recognized that one of the problems with acute, or one of the reasons why patients progress to severe pancreatitis, is because of the hyperperfusion of the pancreas. And so in the 1990s, there was a drive towards aggressive fluid management with hydration, although there was no hard evidence or guidelines. Then in 2013, the IAP guidelines came up, which advocated aggressive hydration for patients who came with acute pancreatitis. This was then later looked at in 2018, who first suggested that actually we should be a bit cautious while giving fluids, and we should encourage goal-directed therapy. This was reinforced in the later guideline, which also pointed out that patients with comorbidities such as cardiac or renal should be more given fluids in a more careful sort of manner. And then the waterfall trial came out, which was published in 2022. So essentially, it was an early weight-based aggressive versus moderately aggressive goal-directed fluid resuscitation in early acute pancreatitis. The sample was 744, and the first interim analysis was done at 248 patients. So it was a very cleverly designed study. It was multi-centered, in 4 countries, open-label, parallel group, randomized, controlled superiority trial. And what they did in this trial was that they compared whether we should give aggressive fluid or moderate resuscitation. So in the aggressive fluid, all of the patient, regardless of their current fluid status, were given a bolus of 20 mils per kilo body weight of fluids. And this was followed by 3 mils an hour of fluids. Whereas in the moderate resuscitation group, they assessed the patients, and only the ones that were hypovolemic were given the bolus of half of the amount, so 10 mils per kilo body weight, and then they were continued again at half of the amount at 1.5 mils per kilo body weight. So if you calculate on average in the first 48 hours, in the first group they gave almost 8 liters of fluids, whereas in the second group it was 5.5 liters. The patients were assessed at 12, 24, and 48 and 72 hours, and if needed, then the patient's fluids were adjusted. And what they found out as a primary outcome was the incidence of developing moderate or severe pancreatitis was not much different in the two groups. So it was almost the same. However, if you look at the main safety outcome, whether the patients will develop fluid overload, so this was 3 times higher in the aggressive group. They also looked at some secondary outcomes, which again were not much different in the two groups. So what they concluded was that if you compare aggressive hydration with moderate hydration, then actually there's no advantage of giving the patients too much fluid, but actually you can cause them harm with fluid overload. So is this a landmark study, game changer? Probably yes. However, it does have its limitations. So the first limitation I mentioned, that because of the findings, it was terminated early and therefore it is underpowered. The inclusion criteria was very strict. In the aggressive fluid hydration group, the fluid bolus was given without the assessment of the fluid status, whereas in the moderately aggressive group, the patients were given fluid bolus only if they had, if they were hypovolemic. And also, if you look at the moderately aggressive group, they were also given a decent amount of fluid at roughly 5.5 liters in the first 24 hours. So moving on to which type of fluids should be given. Should we give normal saline or ringer lactate? And this all stems from this original study in 2011, which included only 40 patients. And what they found out was that if you give ringer lactate, then the chances of developing systemic inflammatory response, or the SIRS, was much less in the first 24 hours. This was confirmed in another study in 2018. However, what this study essentially showed was that the advantage that you gain in the first 24 hours does not then stand after that. And also, there was not much difference in the mortality or the hospital length of stay in the two groups. So although over the years the tilt has been from moving from normal saline to ringer lactate, we're not still very clear whether that's the best approach. There is a Waterland trial that has been conducted. This is an international multi-center, open-labeled, randomized controlled trial. Essentially, it is designed to compare normal saline versus ringer lactate. The recruitment started in June 2023, and data collection has now been completed in December 2024. There are 792 participants, much larger than the previous 40 participants in the original study. However, the results of this trial are still awaited. What about monitoring the patients with acute pancreatitis? How do you monitor the patients that you give fluid? So previously, the old approach pre-2000s was that you just did clinical monitoring with heart rate, blood pressure monitoring, and urinary output. However, what they found out was that essentially there was no standardizations, and therefore the results were quite variable. So in the early 2000s, there was a drive towards moving, in addition to the clinical parameters, to laboratory-based parameters. And 2 of these parameters, including the hematocrit and the blood urea nitrogen, popped up as indirect markers of the perfusion of the pancreas. So if you can imagine with the hematocrit, if it goes down, then the patient has got hemodilution, which can be an indirect marker that the patient is well hydrated. And with regards to the blood urea nitrogen, it tends to go down if the kidney is well perfused. So if the kidney is perfused, the pancreas will also be well perfused. And therefore, these 2 markers do stand out. Also, there has been a shift towards reassessing these patients quite frequently, every 6 to 8 hours for these parameters. More recently, in the guidelines, there has been a shift from aggressive to moderate hydration, especially if patients have got comorbidities. And now we don't use the one-size-fits-alls, but use a goal-directed therapy with frequent monitoring every 4 to 6 hours. We may use dynamic markers or non-invasive cardiac output measurements if we have got sick patients. So, in summary, for fluid management of acute pancreatitis, there has been an evolution over time. So, although we knew quite early on that early intervention is important, the amount of fluid was not very clear, and there has been a shift from the aggressive hydration to moderate goal-directed hydration. There has also been a shift from saline more towards ringer lactate, although the Waterland trial is still awaited. Clinical monitoring has moved on from not only being clinical but also biochemical, and moving away from just one size fits all to a more tailor-based regime. So the final verdict: use moderate hydration, use ringer lactate, and monitor the patient not only clinically but also biochemically. This is now reflected in the latest guidelines, which suggest prioritized functional endpoints over fixed volumes, and the more recent guideline suggests, that you should give individualized fluid therapy. Thank you.
Thank you, Dr. Shazad, for your detailed presentation on the fluid management in acute pancreatitis. I'm once again going to invite Professor Ghayasud Nabi Tayyib on stage, and he'll be discussing the PSG constipation guidelines rollout.
He's not here, I think.
Your camera, sir. Should we move to the next?
Should we go with the question answer session now?
Question answer session. Okay. To follow. Okay. Take. Take. So. ठीक. So we are going to our next presentation, and it is a recorded presentation by Dr. Muhammad Khalid Hassan, who is Medical Director, Center of Interventional Endoscopy, University of Florida, and he will be talking about endoscopic ultrasound learning made easy.
This is online session or what? Next session with us. Recorded in a session. Next session. I think this will be next session.
AI is in this session.
No, the Khalid's lecture in the next session. No.
And today I'm going to be briefly talking about some of the future trends in GI, especially in endoscopy. First of all, I'd like to really thank PSG President Professor Shiraman for allowing me this opportunity, along with all the organizing committee for making it possible. I apologize I could not be there in person due to some personal reasons, but I hope that you'll enjoy this session, and I will be available for the question and answer sessions at the actual symposium. So we're quickly going to go ahead and get started. So this is going to be the brief overview of how my talk is going to go. I'm going to briefly touch upon some of the timeline of advancements in endoscopy. We're going to shortly talk about, how endoscopy has evolved over time, and where are we currently at this time in history? What are we able to do nowadays? And that's going to lead us into the two topics that I'm going to start to focus a little bit more on, which would be endorobotics, a relatively lesser known field in the GI space, and is robotics going to be the future for third space endoscopy, and why we think so, that this could have an impact on how we perform third space endoscopic procedures. And then I'm sure all of you are curious about some of the AI applications and how they can make an impact within our daily GI workflow, starting from endoscopy to seeing patients, and how it can actually help us do our task day to day when we're seeing patients in the clinic as well. So my focus is going to be primarily on the last two topics where we're going to spend most time, but we will still briefly cover some of the above first few topics. So if you look at the brief history of endoscopy, we've come a long way. The first described concept of endoscopy was reported back in 1868 when Adolf Kussmaul performed a first esophagoscopy after boring the idea of endoscopy by a sword swallower. That's the first reported endoscopic procedure that was performed in history. And over the years, we have evolved over time, where the first fibroscope was first brought into play by Basil Hersowitz. And since then, there has been a tremendous explosion how we have utilized endoscopy over time. Especially in the 1970s, when the therapeutics came into endoscopy, especially with polypectomy, then ERCP coming into play in the mid 1970s. And then from there on, there has been a tremendous explosion of how many different things that we're able to perform now. Now, since our topic also includes discussion about robotic platforms, the first concept of robotics, that we see in literature was in early 2000s when Notes procedure was becoming more and more into focus, and that's where some of the robotic platform research actually occurred back in the day. And then it sort of fell off the radar, and then it's starting to make an impact again, and we'll talk about why that is the case. So if you look, we've had a great success in terms of where we started and where we've actually come up until now. If you look at the endoscopy and where we are today, it's exploded over the last 10 to 15 years with definitely some new domains that are coming into play for the practice of GI and endoscopy. It can be all the way from performing mucosal resections and performing ablations to having new imaging and devices, which would actually be able to tell you the texture, color, sometimes histology, sometimes size, all the way to giving you cancer depth information as well. Then the whole field of third endoscopy has come about in the last 10 years and really has revolutionized some of the stuff that we do in terms of further advanced resections that we're now performing. Similarly, endoscopic anti-reflux procedures have really made it into the market. Multiple different kinds of procedures that are now available that we're able to employ to help treat our patients. Similarly, endoscopic ultrasound has moved on tremendously from being a diagnostic area to a therapeutic platform with expansions into a lot more different techniques that we're able to employ using endoscopic ultrasound platforms. However, for the sake of this presentation, I'm going to focus a lot on these two areas. Artificial intelligence, it's a huge area. We may not be able to cover everything in that space. However, I will try to give you a primer as to where things are and where things might be going in the next 10, 15 years. And similarly, I'm going to focus a little bit on robotics and how it's making its comeback within the field of endoscopy and why I think this is an important area to be looking out for over the next few years. So let's move right into. So talking about robotics, it seems like it's going to have a comeback now where it can really help us, bridge some of the things that we do with the surgeons, in the space of resection, in the space of oncology. And really, it sets the stage for us to be able to better collaborate with some of our surgical and oncological colleagues to better provide care for our patients. And, just because of that reason, we have to learn a lot of that information from our surgery colleagues, who I feel have been a little bit more advanced in the fields of robotics than gastroenterologists have been. So if you really look into the literature, the first robotics platform that we have known about made its way into the surgical domain in the 1990s, especially in 1994 when the first robotic platform were approved by the FDA. And since then, there has been a tremendous amount of improvement in different kinds of platforms. And now pretty much it's the standard of care for performing all major surgeries robotically, which helps with outcomes and, patient reported outcomes as well. However, if you look at how robotics has made its way into the GI world, it was around the time of 2000s when NOTES was taking off. So NOTES is natural orifice transluminal endoscopic surgical procedures that were established or brought into the field to be able to perform more minimally invasive procedures utilizing the GI luminal space. So surgery went, through evolution from open surgery to laparoscopic surgery, and then using the same principle, NOTES came into existence where you can actually insert an endoscope, a flexible endoscope through some of these natural orifices, and then be able to get into the peritoneal cavity to perform minimally invasive surgeries successfully using either transoral, transcolonic, transurethral, or transvaginal approaches. Now, this is where we were trying to move in early 2000s. However, when experts, when they started to perform NOTES procedure, they realized that contemporary flexible endoscopes that we are used to that we use to perform endoscopic procedures were felt to be inadequate in terms of performing NOTES procedure, and there were several different reasons for that, which are highlighted here. They all offered very limited degrees of freedom. So degrees of freedom of different various planes that endoscopes can move in terms of, maneuvering, in terms of performing complex procedures. So all the endoscopes had very limited degrees of freedom. They lacked triangulation. So when endoscopist is performing procedures, they're not able to use both of their hands in a triangular fashion, which is also shown here, like in a crab-like configuration, where you're able to actually use both hands to either lift, track, or use them as a counter traction device where you can perform dissections much faster, much quicker. So the conventional endoscopes were noted to be much more deficient in these areas, and also with very small insufflation ports. There was not enough insufflation within the luminal cavities to be able to perform more complex procedures. And similarly, the views were limited to only 2D views, whereas if you look at how the robotics perform in the general surgery space, it's more of a 3D view in a more of a spatial way that you're able to have a better idea of the space that you're working in. So that's where endoscopes were noted to be suboptimal in performing more complex procedures due to lack of some of these things. So that eventually, these deficiencies in terms of the flexibility of the endoscopes, that eventually led to the literature moving away from NOTES and more towards the third space endoscopy. So that's when the third space endoscopy was born, when there was limitations in terms of performing NOTES procedures. And that's when ESD and some of the other third space endoscopic procedures like POEMs or full thickness resections or submucosal tunneling procedures came into existence, where endoscopes could still be utilized to perform some of these complex dissections. However, if you look at that, performing third space endoscopy is not a simple task. It requires a very steep learning curve, still limited in the hands of the experts who have done extensive training in performing some of these procedures, because these are much higher risk procedures compared to general endoscopic procedures. High risk of perforation, takes longer, still limited freedom of movement, where you have to move around in different planes endoscopically to stay in the planes that you're targeting, with very little counter traction, and having to use things like caps and clips to be able to provide counter traction. And similarly, not able to function in a triangular fashion utilizing both hands. And that was one of the major limitations in terms of learning third space endoscopy, where the operator has to go into multiple different orientations and rotating the scope into multiple different planes to be able to achieve better visualization, injections to increase the submucosal space to be able to safely perform these procedures. So these are procedures that are still limited in terms of generalizability in expert hands, which then brought this whole concept back if endoscopic robotic platforms can address some of these mechanical issues that are being faced by endoscopists and be able to have these platforms be readily available to general endoscopists who may be able to achieve some of these complex resections. So we're not going to talk about every platform that is available out there, but I'm going to just try to give you one example of a platform which is called the endoluminal surgical system. It's a very smart robotic platform that uses a concept of a human console where an endoscopist could be sitting, utilizing both of their hands, just like how a surgeon would sit on a console and then perform procedures. And the actual procedures are being performed through this device, which is a slightly larger sized endoscope called a calibroscope, and it has multiple different added ports compared to a regular endoscope. It can still fit in a regular endoscope, but it would have extra ports to bring in some extra needed devices, which could be forceps, which could be cautery knives, which could be different kinds of needles, which could be scissors, which could be rat tooth forceps. And then it also provides operators with a bimanual control, where you can grab with one side and then be able to resect or dissect with the other device that can be going through the other port. And similarly, this console can be operated through a foot pedal where you can steer this calibroscope forward and backwards by just a single operator. So some of these innovations have really come into play where it can actually make some of the job for endoscopists much easier in terms of performing complex resections. So this is sort of a side-to-side visualization of how an ESD would look like in real life and how a robotic procedure would look like. So if you look here, the endoscopist is having to inject, trying to create more submucosal space to avoid perforation and be able to have a better visualization. If you look at it, they'll have to create a tunneling technique. Also would have to go into multiple different orientations in terms of keeping the plane in view and avoiding any resections or complications that are along the wrong planes. So if you look, they're having to really reorient and repeatedly orient themselves in different areas in terms of keeping the view, keeping the appropriate view, and then having to use the same channel to be able to perform, hemostasis and also cautery, and having to do, a lot more different complex procedures at the same time. Whereas if you now look at how the robotic platform can help us with that, it would give you the ability to have a counter traction with one arm where, endoscopic scissors or other different kind of instruments like knives can really help, perform more of a sword-like fashion resections, which can achieve results much faster and quicker, where you're able to actually see better with counter traction. You don't have the need to perform a lot of submucosal injections to create space. And at the same time, it gives you a much quicker and easier ability to be able to eventually, at the end of the procedure with larger defects, be able to kind of suture those defects using a bimanual control, just like how a surgeon would be able to perform these procedures in a real time. So this is how, how a robotic platform can definitely make things easier, better, faster, effective, and possibly safer for our patients as well. So just wrapping up, some of these robotic platforms and the pros and cons for that. The pros are definitely, there's two arms that have increased degrees of freedom. Endoscopists can perform better triangulation, traction, and counter traction, which can overall then increase better ergonomics, dexterity, and precision for the operators, with decreasing mental and physical workload overall, decreasing procedural times, and decreasing adverse events, and definitely can have a much faster learning curve for endoscopists who are new to these techniques, and a much quicker and faster learning curve on these platforms. However, the cons that have made it not readily available are its larger size. The devices that are currently in play have much clunkier, larger sizes that are able to fit in small rooms. It's not available widely with limited access at this point. And the learning curves, not just for the endoscopists, but the other people in the unit, including assistants and nurses, continues to be a challenge at this time. And again, since it requires, setting up a larger platform and a setup, requires turnover time. And then, you have to take into account the overall cost effectiveness of these platforms before it can be utilized in a general fashion overall. However, I think one area that actually it can really help, with robotics is that surgeons have been able to perform telesurgery just using robotic platforms, where they're able to have access through high-speed internet to a remote location where they can just sit on a console, be able to perform complex procedures, remotely. We haven't been able to get into the field of teleendoscopy for the exact same reason that, you can't operate endoscopes from a remote platform. But having robots in endoscopy, utilizing the same concept of what the surgeons have been able to do, it may be able to let us perform teleendoscopy in places which may not have physician workforce available in a readily fashion, and be able to perform and educate even services that are far flung and in difficult to reach areas. So in conclusion, incorporation of robotics into GI will offer broadening the practice for complex procedures, I feel, over time. It will improve clinical experience and outcomes for more complex procedures that are currently being performed in a subset of hands. It definitely would be able to reduce more mental and physical workloads with improving dexterity and precision of such procedures as well. And incorporating AI platforms within robotics, I think, is going to be a thing to watch out for in the interventional endoscopy over the coming years. I think these two are going to have a lot more interplay over the coming years to be able to perform better for our patients as well. Now, quickly moving into the space of artificial intelligence into the field of gastroenterology, I think a few terms that are very important to understand as we go further into this. Majority of the people are familiar with artificial intelligence platform, where platforms are able to help, detect, diagnose certain things just based on visual and voice prompts. But now, over the last few years, in the last 2 to 3 years, we've moved into the field of what is called generative AI, where algorithms can, based on a prompt, generate text and images based on the existing data that is out there. So generative AI is making a huge impact into our day-to-day practice, and I think it's going to continue to have a further impact as we further streamline some of these platforms as well. A few other concepts that are coming in. One is called agentic AI, which is pretty much a platform that works as a personal assistant. It is such a sophisticated system where it can exhibit autonomous goal-directed behavior in complex environment, where you can give a prompt to a platform which can then create a full itinerary or a workflow for you based on repetitive patterns that it has picked up over time. And so it has moved on beyond from passive data processing or task execution to actively planning, reasoning, and taking initiative by executing certain things to achieve objectives with very little human interaction. So some of these things are really going to make an impact in the coming years. And then, we're also getting into the space of ambient clinical intelligence, where the data is being just collected in a very passive fashion that is happening around you. The systems that passively monitor everything that is going on in the environment, and then is able to create documents that would actually help you better outcomes for our patients. It can scan large computer databases and be able to generate reports and spreadsheets that would tell you about some high risk conditions in certain patients. Similarly, stuff that can be accumulated based on some of the medical devices that are being utilized, heart rate monitoring or blood pressure monitoring, O2 sats. So all these, continuous data points that are being generated, ambient clinical intelligence can use those and look at the trends and can generate a report for you to be able to then present for a personalized care toward your patients. If you look at how this has progressed in AI studies over the last 20 years, there's been a true explosion in the field of AI. If you look, just in the space of polyp studies, and we're not just talking about stuff that has happened within overall the field of GI and digestive endoscopy. Just in the polyp side, in the last 20 years, there have been over 600 articles published by more than 2,900 authors in over 200 journals, from all across the world. And if you look, these are just the studies that are in the space of polyp detection. But if you look at how many AI studies have actually happened over these years, including the number of studies, including endoscopic visuals and platforms versus endoscopic or GI workflow, it is just remarkable. I think, when you look at AI has made its impact in every area that we deal with within the space of GI. So, you name it, and there has been some sort of a study that has already been performed within this field, starting from upper GI, small bowel, colon, GI bleeding, inflammatory bowel disease, assessing histology, figuring out dysplasia, you name it, and there has been a study that has already looked into in current times into that space, hepatobiliary space, pancreatic cyst, pancreatic cancer. So all of these areas have already had studies performed. So the question at this time, that we have to ask ourselves is, not just what AI can do at this time, is it truly what AI cannot do? So pretty much every area that we are looking at in our regular practice, there are platforms that are being developed and being validated that can help us. So if you really look at as to where we are in terms of applications, most of you must have been aware of, some of these CAD-eye systems, where endoscopic lesion detection systems are readily available that can look at polyps.
Our apologies for the slight deviations from the pre-designed schedule. Now we are moving to our last presentation in the session number 6, and it will be endoscopic ultrasound learning made easy by Dr. Mohammed Khalid Hassan from USA.
Constipation. Constipation is after the session. I thought it was in the schedule. It's after the QA is constipation. This session.
I'm going to do my best to make it easy in next 20 minutes. Mainly, I would be giving a little bit of introduction about EUS, then talking station and organ-based approach. Most traditional teaching is station, like station 1, 2, 3, 4, 5, 6. I have a little bit different approach to those stations, but I'll talk about that. And then very briefly, because mostly we use EUS for diagnostic purpose, which is tissue acquisition. So I'll talk briefly about that as well. Again, about the history, just like I did in ERCP, EUS started in the 80s. First, it was just a radial scope, mechanical probe. In 1991, linear scope came. Radial was mainly, it's a 360 view, mostly diagnostic. Linear was for biopsy and therapeutic purpose. First FNA was performed by Dr. Peter Wellman in 1992. After that, other modalities like CT scan, MRI, they mostly were being used for staging, and EUS role in staging decreased. And now it's mostly a therapeutic modality, just like ERCP being therapeutic modality. Not that EUS does not have a diagnostic role. It does have a diagnostic role. And even FNA, FNB, it's basically a diagnostic role. But its role in therapeutics is increasing. Its role in interventions is increasing. Technology has changed. It was very bulky, mechanical before, and now it has become much more sophisticated and much more user friendly. EUS, I would be focusing mostly on diagnostics, which is the imaging, examination, and a little bit about the FNA, FNB. I would not talk about liver biopsy, which is totally a separate topic. Therapeutics, interventions, you can see, and you know that we use EUS for a lot of interventions now. These three scopes, basically radial, linear, smaller one in the middle, baby scope, bottom other on the sides, baby scope in the center. That baby scope basically is endobronchial scope, or EVA scope. 360 scope for what a 360 image, or radial scope, I should say. It's just like a CT scan image, axial cuts. In this, needle could be put in, but you don't see it because needle really is not in the pathway of those ultrasonic waves. It just appears like a dot. That's why we don't use radial for any sort of biopsy or therapeutics. On the other hand, the linear itself, the needle, which comes right in front of the transducer, and those rays, ultrasonic rays, they're covering the whole needle. That's why you're able to see a needle and be able to do biopsy or therapeutics with a linear scope. It's equipped with Doppler capabilities to tell you about the vessels, allows direct visualization of needle, as I said, and for that purpose, we use it for therapeutics. Radial, not many people using anymore. It's really a lost art, but still has a role. Majority of the work now could be done with the linear, even the diagnostics as well. The era I trained in, it was 50-50 radial and linear, but nowadays the fellows are coming out of training mostly. They are only trained in linear. They don't have much orientation about the radial. In our program, we still teach about radial to some extent, but mostly it's linear. So what do we use EUS for? Upper GI tract, intraluminal examination like esophagus, stomach, duodenum, and extraluminal. I will focus on the mediastinum, pancreas, and the biliary tract in this presentation, but we pretty much can see the whole liver with the EUS. Maybe not able to see every single segment of the liver completely, but we at least see a majority of the left lobe of the liver and all 4 segments of the right lobe. We can see may not be the whole segment, but at least a part of those as well. Other structures, vascular structures which are close to the lumens, like esophagus, stomach, and duodenum, spleen, as thyroid gland, so anything in proximity to the upper GI tract, we can see that. A little bit about the anatomy, those layers of the wall. There are basically 5 layers. You can see here when you use EUS, radial or linear, there's a first white, then black, then white, black, white. First white is the epithelial layer or mucosal interface or mucosal layer. Then there's the first black one is muscularis mucosa or a deep mucosa. Then white is the submucosa. Black is muscularis propria. Muscularis propria at higher imaging, we can even see the circular and the linear muscular layers as well. And then there's another white layer outside muscularis propria based on where the scope is. If it's in the chest or mediastinum, esophagus, I should say, it would be adventitia. If it's in the below the diaphragm, it would be serosa. So these are those layers with the linear. These are they become a little bit more visually apparent in radial imaging. Other terms to remember, like anechoic, hyperechoic, we use that terms in EUS. Fluid is black. Blood is flowing blood is black, or what we call anechoic, has no echogenicity. But the clotted blood, however, looks hyperechogenic, and so does the fat look hyperechogenic. Debris, stone, hypoechoic, usually inflammation, and the neoplasm they look hypoechoic. So principles of imaging, station-based, organ-based. Let's talk a little bit more about that. But one few important points I want to make is that when you do a US, make the anatomy fit at the station. Don't assume at the station-based your interpretation. And if during the EUS in the beginning, and even sometimes you get lost, and if it just spend a minute away, if not possible, come back, find the most familiar station like aorta, big organ, which you are familiar with, or duodenal bulb, and then start over and go from there. It's usually very gentle movements, shoulder movements, wrist movements, and the scope being straight. That's how it's gonna really help you master this modality. Use Doppler as needed. And the most important thing to remember is position of the scope, movement of the scope, changes the orientation of the structure. If you're looking at the pancreas from the stomach, consider it looking from up down. You'll see a pancreas, you may see a portal vein, the bile duct being away from that. But when you are in the duodenal bulb, everything flips. So that needs to be mastered, that orientation of the organ is going to change based on where you are, long position, short scope position, looking at the organ from the stomach or from the duodenum. So that constantly changes based on where you are. To give you a little schematic idea, when you put the scope below the junction linear, this is the those ultrasonic rays you are looking at. If scope is coming into the stomach, And that's your area of examination is. Like when you're rotating to the right, going to the distal body and tail, rotating to the left, you are going to the um, neck of the pancreas. And once you are in the duodenal bulb, orientation changes. Look at where the plane of examination is, where those the structures you are examined. Again, just to stress, like the orientation of the screen is going to change based on exactly where you are. And this is when you are into the second and third part of the duodenum. Look at that, how the orientation of those rays is and what you're looking at, because everything which is close to the transducer is going to be first appearing closer upwards, and the rest of the structure is going to be away from that area or from that orientation. So here, looking at it, neck is away and the uncinate was closer, but when you're pulling the scope back, the constantly changing orientation of that. For me, the station-based approach. There's stations were made when the U.S. Was started in the beginning. So that started from third part of the duodenum, second part, duodenal bulb, stomach, mediastinum. So the station started 1, 2, 3, 4, 5, 6. First being third part of the duodenum. For me, I have my own different approach. For me, the stations start as the stomach, duodenal bulb, second part of the duodenum, and then esophagus or mediastinum. So that's my approach. For me, the first station is always below the GE junction going into the stomach. So this is how my approach. But follow an approach which suits you, but follow the same approach every single time for every single patient. Keep repeating. And so it becomes a habit like riding a bicycle. You don't have to think, or driving. You don't have to think. Like it becomes a habit and follow the same pattern every single time. In this case, when I am into the below the GE junction, I usually inflate the stomach. I know ear, and you know ear is the enemy of the ultrasound, but I inflate to get an idea about where the distal gastric wall is. So I inflate the stomach, take my transducer to the opposite wall of the stomach, suction all air out, collapse, big wheel towards me, will take me to the left lobe of the liver. Pull the scope back, rotate right and left until I find the aorta. Once I find the aorta, I follow the celiac. I find the celiac axis, celiac artery, and SMA. I will focus on celiac artery, divides into left gastric, common hepatic, and splenic. Then I've gently let my big wheel go to free the scope, advance the scope, follow the splenic artery that will take me to the pancreatic body. Once I get to the pancreas body, and you can see here the scope position rotating right and left. One thing is to remember is whatever you want to examine should be, or do your best to keep it between 5 and 7 o'clock position. So this is your, anything you want to examine should be in this triangle. Not going to be possible every single time. It may be on the side, but do your best to keep that orientation. And other thing to remember again was, as I mentioned in my previous presentation, is the camera is at 45 angle, meaning where the wall and the ceiling meet, and the transducer is at least 1.5 to 2 centimeters beyond the camera. So if you are looking at the wall, looking at the pylorus right there, and your transducer is already at the lower part of the antral wall, you're not going to be able to get into the duodenal box. You have to pull the scope really back and the big wheel towards you to get into through the pylorus into the duodenal bulb. So again, coming back to, this is my number 1 station, which is going to be celiac artery. Follow that, pancreatic body, tail. Then I go towards the neck, And that also, you can see the splenic vein, SMV, making a portal vein, going towards the liver downwards. So in duodenal bulb, liver is going to be up here. In the stomach, when you're looking at it, it's going to be down up right here. So body, tail, neck, liver, portal vein, bile duct. That's the orientation from the stomach. This is going to completely going to flip when we're in the duodenal bulb. Okay. Other thing I want to you to do is take a look at the anatomy atlas. You have all that Frank Natter atlas or whatever anatomy atlas you use. You have seen this page. This is the stomach right here. Pancreas is behind that. There, spleen. That page out of to learn EUS really. This is the orientation of the EUS of this station right here. So the way you will understand that is take this page out, flip it upside down and look in the light. That would give you this orientation. So first you're looking at the page, flip it, look under the light. This is the orientation which is going to come. That is the orientation of your EUS. Now see right here. Left kidney, spleen, same image EUS. So just wanted to show you like how the EUS image is going to show as compared to the textbook and the CT scan. CT scan, axial image looks like this. Your kidney, spleen, pancreas, exactly same with the EUS. Regular textbook, flip the page, look under the light, give you the same image. Station 1, 2, 3, as I mentioned earlier, these are the textbook stations, but for me, the station 1 was, which I just explained, the stomach. Second station for me is the duodenal bulb, when the scope is in the long position going into the bulb. Third station for me is the second and third part of the duodenum, but I'll go over that in the next few slides. So coming to the duodenal bulb, you can see here the scope is resting on the greater curvature. Earlier, your scope was here when you were in the stomach. You are looking at the pancreas right here from the top down. Now, consider it, you're going into the duodenal bulb and looking upwards. So what that does flip your image completely. Now your liver this is what you're looking at. Now your liver goes up here, bile duct here, pancreatic duct here. This is the head of the pancreas. Your uncinate is going to be here. Your neck of the pancreas is going to be here. Body would be distal, tail would be the other. So pancreas has completely flipped when you are in this position. In this case, what I do is I find the bile duct, pancreatic duct, and the portal vein, which is going to be in this close, or what we call a stack sign. Follow, rotate to the right to go to the papilla. There, follow the bile duct towards the. Here, when you get to the liver hilum, follow the portal vein, right portal vein, you are able to see all 4 segments of the right lobe of the liver. But again, not some other time, we'll talk about that, how to do the liver examination. But from here, just make, again, a habit going to the papilla, and from papilla, going to the hilum, couple of movements, you will see the bile duct, you see the pancreatic duct, papilla, head of the pancreas, uncinate, a portion of the neck of the pancreas as well. So next is, and this is, I just talked about that. Next is going to be images. So once you get to the second part of the duodenum, try to look, shorten the scope, try to look at the papilla with the endoscope view. Not going to be possible always, but if you find it, put your camera right on it. Again, remember, you're putting the camera right on there. So where is your transducer? Your transducer is centimeter and half to 2 centimeter beyond the papilla. So you have to pull the scope back to really get a pancreatic and papillary examination. Once you're pulling the scope back, rotate right and left. Your goal is to find the aorta. Once you find the aorta, In the center, you rotate your scope left, you will see IVC. You rotate further to the left, you will see right kidney or segment 5 or 6 of the liver. From the once you find the aorta should be in this position. Rotate the scope a little bit to the right. First thing you would see is the bile duct. Next thing you would see, this is the first thing, you would see bile duct. Next thing you would see is the pancreatic duct. If you rotate further, that would be your unsnake process. You have not seen the unsnake process completely until you see the mesenteric vessels, which are going to be right here, superior mesenteric vein and superior mesenteric artery. So that's how you do examination there. For mediastinum, station 5 and 6, if you keep the scope straight in neutral position, means views facing up, and pull the scope back to 30, rotate a little bit right and left, you will see the left atrium and the pulmonary artery. The area between those is the subcrina. If you come back further, like a couple of centimeter, 1 to 2 centimeter, wheels facing downwards, that would take you to the descending aorta. And once you find that, pull the scope back, bring it to the aortic arch, big wheel towards you, and now rotate the scope a little bit to the right so wheels are facing to the patient, and that would take you to your aorta pulmonary artery or AP window, what we call EUS AP window. These are the different positions. You can see in the mediastinum or in the esophagus based on your scope position, what you are seeing, A, B, C, and D. Moving next. This is I'll spend a minute on this or so. This is the complete EUS examination. You see that what I was saying, going to the opposite wall of the stomach. Now I'm at the big wheel towards me, suctioning the air out, takes me to the left lobe of the liver, rotating the scope to the right and left to find aorta. This is my celiac. Following that, this is splenic. Following splenic takes me to the pancreas itself. This is the pancreas itself. You see the duct right there, rotating the scope to the right to the distal body, pulling the scope back a little bit, takes me to the tail, and I see the left kidney starts appearing right there. I still have not seen the tail because I have not seen the spleen yet, so I'll pull it further back. Once the spleen comes, there is a spleen. That means I'm getting close to the tail or splenic hilum. The tail of the pancreas is kind of tucked in between the spleen and the kidney, now rotating backwards or anti-clockwise to go towards the neck of the pancreas. You see the splenic, SMV, making a portal vein right there. Bile duct is right here. Now this is a portal vein, bile duct. Portal vein that was following towards the liver right here. Liver was right underneath in right lower corner. Now getting to the duodenal bulb. Same thing, once you got to the duodenal bulb, just remember that you should not be seeing pylorus while you're trying to get into the duodenal bulb. Pull the scope back a little bit. So once you get to the duodenal bulb, put the transducer into the duodenal apex in left upper corner. Suction, big wheel towards you, will take you to the bile duct or pancreatic duct or the portal vein, what we call the stag sign. So once you have seen one of those, follow that first to the papilla, then towards the liver hilum. And you can see right here, that's a bile duct, pancreatic duct coming right here, papilla is right there. The portal vein this was a portal vein. You saw splenic was now coming from that side actually, and SME at the bottom because the orientation changed. So making a portal vein and going towards the liver. Then go to the second part of the duodenum, which I mentioned that earlier. You saw the aorta there, rotated to a little bit to the right, bile duct, pancreatic duct. And here, this is a ventral pancreas, a little bit less fat as compared to the dorsal head of the pancreas. And from there, just gently moving the scope back, releasing wheel, unlock, and just pulling back, keeping the pancreas underneath the transducer.
I'm sorry for breaking the bad news that we are not having the question and answer session. Before concluding the session, I will like to pay my thanks to all my chairpersons and to all of you for your patience listening. And with this, we conclude the session, sir. And now I am going to invite Professor Dr. Yasin Nabi Tayyib on stage who is the ex-president of Pakistan Society of Gastroenterology, for PSG constipation guidelines rollout.
Thank you very much. PSG consensus guidelines on constipation. These have been rolled out just recently, and they have been published in Pakistan Journal of Medical Sciences. There's been lots of effort by the contributing authors. So, can I request Professor Sherman, Dr. Kamran, Dr. Nazish, can you please come to the stage? Professor Sherman, please. I'm really thankful to Martin Doe Company for helping us in organizing these guidelines, preparing the manuscript, and then finally helping us in getting this published. So, yes. Where's Professor Sherman? Charlie. So, uh, PSG has a tradition of developing the consensus guidelines. Previously, they have done it in hepatocellular carcinoma, gastroesophageal reflux disease, on IBS, and in continuing with the same effort, this time we are revealing the guidelines for the benefit of the family physicians, for the young doctors, and the people who are working in various hospitals. The copies of these guidelines are there with you. So these have already been published. It's a very well written script. So can I request all the authors, and first of all, Dr. Lubna, she has worked very hard to prepare these scripts. So Dr. Lubna, can you please join me in moderating this session? So the other authors, Dr. Lubna, please join us. तो इधर आ जाना, ये हम दोनों मिलजुल के कर लेंगे. So in addition to Dr. Nazish, who has been part of the preparing these guideline script, Dr. Nazish, Dr. Amanullah Basi, Dr. Shahid Rasool, Professor Dr. Zahid Azam, Dr. Tayyib Saeed Akhtar, Professor Shahab Abid, I think he is not here. Dr. Bilal Nasser, he is not here. Dr. Sajjad Hussain Sabe, and Dr. Kashif Shafiq. So thank you very much, all of you, for being here. Can I request Professor Sherman to please come and say a few words on these consensus guidelines which are being revealed today? There's a few words you got.
Bismillahirrahmanirrahim. Thank you all for sitting at the lunchtime for this activity. I congratulate the committee that had worked really very hard to come to a consensus guideline under the guise of the Pakistan Society of Gastroenterology. Thank you all.
Thank you, Professor Sherman. Dr. Lubna, would you like to say something and introduce all the authors? Please.
Authors are all eminent gastroenterologists, so there's no need for introduction. But yes, constipation is a very common symptom, and surprisingly, there wasn't any consensus guideline from Pakistan. So the concept was actually started 3 years ago, and it took 3 years to make a team like-minded, representing all areas from Pakistan. And then we worked mostly virtually on Zoom meeting. We have to spend hours on Sunday, and then the draft was finalized last year. Those who remember that we finished the guideline last year, and we discussed various strengths and weaknesses of the guideline and what are the details. And then it took 1 year for the process of publication, basically. And this year, fortunately, I'm delighted that the guidelines were published in Impact Factor Journal, and it is there for us to, have a reference whenever we are stuck. And it's basically for the general practitioners, the students, the internist. So basically, how the journey began. So I would request each author to the questions which I'm asking to answer in 1 to 2 minutes in the interest of time. So we'll start with the the most eminent gastroenterologist, Professor Gyasun Nabi Tayyab. How do you find the journey from starting the concept till the end, till the rollout? And this is not the last step. In fact, it would be the beginning of the next step, which is taking these guidelines to all the general practitioners and each and every corner. So, how do you find this journey?
Thank you, Dr. Luptan. And first of all, let me admit that I'm not an eminent gastroenterologist. Eminent are obviously two ladies, one after another. So these are two ladies which are the most eminent gastroenterologists, and we just trail behind. And that's how the thing started. Because once the concept was advertised that we don't have any functional constipation, it was realized that in pregnant females and females, this is something relatively more common. In elderly population like us, it's relatively more common. So younger people, they joined us. We started to deliberate on this issue. The people who are interested in neurogastroenterology, they took the lead, and slowly and gradually, with the efforts of all, the things have started. I must congratulate Tayyib in particular, because he made a small video in particular on this issue, how to defecate properly and how to look at your bowel pattern in a careful fashion. So that's how the journey started. So I'm sure my other colleagues are going to talk about it in more detail, so I'm not going to take more time. I shall let the other people speak.
Now, my question is to the elegant lady of gastroenterology, Professor Nazish Bhatt. How do you find this publication would be useful to the masses?
Thank you, Dr. Lubna. First of all, it's very important to publish guidelines from the platform of societies like Pakistan Society of Gastroenterology. We always look forward to other societies for the guidelines. So I would like to congratulate the whole team, and I would also like to thank the Martin Daw for sponsoring this whole activity in the publication of this guideline. So this is very important, and it will help out because in OPDs, my residents always asking me about what to give, and most of them are giving this lactulose to all the patients. So I always guide them how to start, how to take history, how to rule out the causes, and then you have to give the medication step by step, lifestyle modification, first line drugs, then other drugs. So it's very important for the society and for the Pakistan to have their own national guidelines on constipation. So I would like to congratulate all the team members. Thank you.
Now I would like to ask the most humble person, Professor Shahid Rasool, that what is the importance of these guidelines? Why there was a need to make these guidelines?
Thank you, Lubna. Basically, the task which was given to me was about the prevalence of constipation in Pakistan. तो constipation इतनी common है हमारे यहाँ, हमारे OPDs भरे पड़े हैं, but when I was searching the literature, there was not a single study from the Pakistan जिसको मैं quote कर सकूँ कि पूरे पाकिस्तान से हुई है. There were just hospital-based studies on students, on patients. तो ये हमने फिर देखा कि हमें कितनी ज़रूरत है कि हमारे पास अपना डाटा हो, कि वी शुड बी प्लानिंग, कि हमें पता हो कि हमारे पेशेंट्स के प्रेजेंटेशन कैसे है, एंड देन कमिंग अप विद द डेफिनेशन एंड ऑल द स्टफ. आई थिंक दैट वाज अ वेरी इंपॉर्टेंट थिंग कि हम अपने लिए, अपने पाकिस्तान के लिए, अपने लोगों के लिए, अपने जीपीज़ के लिए कुछ गाइडलाइंस बनाएं ताकि जिसकी बेस पे वो पेशेंट्स को मैनेज कर सकें. एंड ऑन द बेसिस ऑफ दिस उस वक्त हमने प्लान किया था कि हमें पूरे पाकिस्तान से कोई स्टडी फार्मूलेट करनी चाहिए, जो शायद हम सब शायद भूल गए हैं. तो मैं आज वो रिमाइंड करा दूंगा आपको दोबारा कि वो उस वक्त हमने डिस्कस किया था कि दैट इज़ द नीड कि हमारे पास अपना डाटा तो हो पहले.
थैंक यू. शायद आपने एलिगेंट लेडी का तो सुन ही लिया, अब उसका जो एलिगेंट मियाँ है जो बिल्कुल साथ ही खड़ा है, लेट मी आस्क हिम कि यार ये गाइडलाइंस का इम्पैक्ट क्या है सोसाइटी पे.
Sir, thank you very much, and thank you Martin Dow. They supported us very well throughout. बल्कि हम कभी भूल भी जाते थे तो उनका बार बार रिमाइंडर आता था कि आपको गाइडलाइन कंप्लीट करनी है. सो कंटिन्यूसली ये सिर्फ एक ही एफर्ट नहीं है, सबकी जॉइंट एफर्ट है. और लाजमी एवरीबॉडी नोज़ के आपके क्लिनिक्स पे कॉन्स्टिपेशन को ट्रीट करना एक रियली इज़ अ वेरी डिफ़िकल्ट टास्क। तो काफ़ी पेशेंट ऐसे भी थे जो मल्टीपल ड्रग ट्राई कर करके थक हार चुके थे, तो हमने ये भी समझा कि दिस इज़ रियली वेरी इंपॉर्टेंट। एंड फ्रॉम द PSG प्लेटफॉर्म इट वाज अ वेरी ऑनर फॉर अस कि हम उसमें शामिल हुए, और ये PSG की तरफ से हमने फर्स्ट टाइम कॉन्स्टिपेशन की गाइडलाइन लॉन्च करवाई। और दिस इज़ नॉट द फर्स्ट टाइम। आई रिक्वेस्ट ऑल दी यंगर ग्रुप और जो ग्रुप यहाँ बैठे हैं उनको भी हम रिक्वेस्ट करेंगे कि फर्दर जो गाइडलाइंस हैं, जैसे कि प्रेगनेंसी एंड LFTs, जैसे एक्यूट फैटी लिवर ऑफ प्रेगनेंसीज है, या प्रेगनेंसी से हट के एक्यूट फैटी लिवर है, क्रॉनिक फैटी लिवर है, फाइब्रोसिस डेवलप हो रही है, ये डिफरेंट स्टेजेस है। तो अभी फ्यूचर जो है वो आपको पता है कि हेपेटाइटिस C के बाद जो फैटी लिवर है विल बी द लीडिंग
या
काज ऑफ
बाजी
द
साहब, आप
फाइब्रोसिस।
मियाँ बीवी जो ना
सो
एक
सो
मिनट की
सो
बजाय
सो
आप ना
सो
5
सो
मिनट
सो
लेते हैं।
सो आई रिक्वेस्ट है कि आप लोग जो है इसमें शामिल हों, फर्दर गाइडलाइन PSG की तरफ से वो भी हम डेवलप कर पाएँ। थैंक यू वेरी मच।
Thank you. The next speaker is talented Professor Tayyab Saeed Akhtar, and my question is, who is the beneficiary of these guidelines?
Thank you very much. It was really an honor to work with the whole team. Actually, when we formulated these guidelines, we kept in our mind that our target audience will be students as well as the trainees, the general physicians, and the consultants and the gastroenterologists. So you will find the information useful for everyone. Like Professor Riaz was saying, I was given a task to make a video on the DRE, how to perform proper DRE. This is basically for the students, and then you will find things for the family physicians, when to refer the patient, how to identify the red flag signs. And for the gastroenterologists, we have also talked about the physiological testing, including the anorectal manometry and even the biofeedback. So the guidelines will gonna be addressing everyone, but this is just the start. It's a consensus guidelines. We encourage everyone to bring more data, perform more research, so we can come up with some more polished guidelines with Pakistani data. Thank you.
Thank you. Last but not the least, I would request Professor Zahid Azam, one of the busiest, gastroenterologist in Karachi town, and he took time for this constipation guideline on Sunday. What do you think the future research on constipation should be? Your half answer was already given by Dr. Shahid Rasool, but
Yes.
how do you think, what is the way forward?
Basically utilizing this guideline, and we should have groups of research as well addressing these issues of constipation. So important thing is epidemiology, and then that we were missing after making the guideline. We promised several times at that instance when we were making guidelines to have this. So we should continue, and hopefully we will have something in future as well for that. We'll meet together again for these for the research.
Thank you very much. And can I ask Dr. Kamran कि he was the organizing VP, तो उनकी conference में guidelines reveal हुई, तो what does he think? What does he feel?
Sir,
Can I ask? Just a minute. Can I request Dr. Atif? He has been my student as well, and he has been helping us a lot in organizing the meetings and in the background work. So Atif, can you join us, please? Ji, please.
Sir, it's an honor that, as Dr. Lubna always mentions, it was Peshawar who introduced Dr. Lubna, and today she is an elegant lady, known in the whole of the world. Although she was elegant, but iron और elegant, ये combination पेशावर में introduce हुई थी, और इसके अलावा जो है तो sir, it's an honor that the guidelines are being rolled out in our meeting. And I hope that many more guidelines are needed for our country, and they'll be rolled out in our next meetings, inshallah.
This guideline was not possible without the unwavering support of Martin Dow Marker. Atif Saab, the entire team of Atif Saab was there on every step, with all the logistic support, the financial support, and Dr. Wakas.
Lubna, with your kind permission,
Okay.
excuse me.
Yeah.
with your kind permission, can I make a point? I think a lot of effort has gone into preparing these guidelines, but my problem with this is that the moment you introduce, I mean, eh, by all means, Martin Dow should, or any company can support them, but in the guidelines, when you look at it, some of the places where they have been, because sulfate mentioned, it has been highlighted. I think that loses its objectivity. So for a society, one can mention that it has been supported by, but it should not be contaminated by, highlighting Lexoperon or whatever, is the drug. So I think to make it credible at international level,
No,
we should make
I'm-
it a,
I'm very-
objective guidelines so that it is, it can be quoted. Here it becomes an advertisement for Lexoperon.
I'm happy you raised this point. This is just highlighted in this print version what they have distributed because they have made the copies. If you go on Pakistan Medical Sciences Journal website, there is no highlight. There is no trade name being used. This is just because they have done this hard copy, so they have put this. But if you go on the journal, the Google, it will not be highlighted. Just in acknowledgement, the name is there because they have supported the logistic and the financial support. That's it. Otherwise, on
Dr.
Pakistan,
Lubna, you can't get any published article with the name of a drug,
No,
which
no,
is
there's no
let me
trade.
complete, please. Which is a trade name. The objection that he has raised, which I support, is that Martin Dow should be there in this. But if Martin Dow cannot afford to publish this, then PSG should publish it. We have enough money. Lexoperon, putting the name of a medicine on a guideline is a problem. Putting Martin Dow is not an issue. But I think in future, we should be careful. And I don't think it's such an expensive thing these days that you create these guidelines in terms of printing. So I think that is something that should be taken into account.
yeah, but Lexoperon is used in this in bracket picosulfate, yeah, trade name. It is used, but highlight is not there in the original article. or
ओरिजिनल में
something.
हाईलाइट कर ही नहीं
Yeah,
सकते ना
well-
डॉक्टर लुबना
well
आप
taken,
आपका
well
पब्लिश ही
taken.
नहीं होता अगर कोई ढंग का
Well,
journal हो।
well taken
What
point.
point
Well
is
taken
being
point.
made is that when
There's
you open
no-
this
yeah, there's
guideline,
no-
you see Lexoperon.
Yeah, this is because the publication was printed by them.
I
and
do
not
sit
by them.
on certain BSG guideline committees.
Agreed.
And I think something like this would never go through it because, and it is just for the benefit of our own, the status
Well
or
taken.
credibility of our own PSG.
No second thought. Well taken. Very well. And thank you for the.
इवन डॉक्टर लुबना मैं मतलब जब हम लोग सदीक सादिक जो प्रेसिडेंट थे उसके बाद फिर हम आए गयास साहब उस पूरे ग्रुप्स में शेरामान थे तो हमारी एक कंसेंसस एग्जीक्यूटिव ने ये किया था कि इवन हॉल में भी किसी कंपनी का कोई बैनर कोई नहीं होगा मुझे नहीं पता कि उस पर आजकल क्यों ये नहीं हो रहा है लेकिन अब हर जगह वो देख रहे हैं तो इस चीज़ों को मेरे ख्याल से ऐसे सोसाइटी हमें देखना चाहिए क्योंकि एक वन को आप एडवांटेज दे रहे हो तो दूसरी को आप डिसएडवांटेज पे रख रहे हो तो सारे पर
डे वन था मैंने पॉइंट आउट किया था कि हॉल के अंदर जो है बैनर्स लगे हुए तो जो मेन हॉल है उसमें एज अ मैटर पॉलिसी आपके किसी कंपनी के बैनर्स नहीं लगने चाहिए दिस इज द डिसीजन ऑफ द एग्जीक्यूटिव कमेटी एंड आई थिंक इट शुड बी इम्प्लीमेंटेड इन ट्रू एंड लिटिल स्पिरिट तो कमिंग बैक टू दिस क्योंकि इसमें इन्होंने तो अब मैं इन द इंटरेस्ट ऑफ टाइम केक कटिंग और उसके बाद शील्ड और वी शुड अनाउंस द लंच इज रेडी नहीं Atif, do you want to say something?
Thank you so much, all the participants and the authors who contributed a lot in the making of the guidelines. And the point which we have just listened from the audience are very well taken. Our objective is not to highlight the brand. It was just a support which we would like to give into the audience and the authors and the junior doctors as well. So thank you once again for the contribution, and we look forward, not confined to this gastro segment. We will definitely explore this guideline and the management of constipation in ped segment, in gynae as well, and other segments as well. So we just have a little video, of 2 to 3 minutes, followed by a reveal. Okay, okay, thank you. So, of course. Okay, so we would like to distribute a shield.